what it is about, so that we are also discussing some more formulas, so just something you can, for example, print out or take a photograph of, so that you simply have it written down. Overall, the main question or the main goal is optimized organ perfusion, arterial and venous. So in the arterial system and the venous system, the oxygen, of course, needs to be transported. You need enough blood to transport O2, and you need to have an adequate cardiac output, so no forward failure, to have it transported. The cardiac output is the stroke volume times the heart rate. The stroke volume, again, is then end diastolic volume minus end systolic volume, or you can calculate it with the VTI of the pulse width Doppler signal in the LVOT and the cross-sectional area of the LVOT. You see here this measurement. This is the cross-sectional area you can measure in the peristernal long axis view. Here's the calcified aortic valve. So here you would place the measurement a little bit over measuring in this area, optimizes the measurement. But if you want to know more about the aortic stenosis and how you perform these measurements, take a look at the videos where the aortic valve and the aortic stenosis is discussed. This measurement, it's always dependent on the stiffness of the left ventricle. Again, diastology and diastolic dysfunction, filling pressures, they are very important. But you can dedicate hours and hours of lectures only to this topic of diastolic dysfunction. The stiffness also induces the systolic wall stress, and even if you put more fluids into the patient to achieve more stroke volume, to achieve more venous return, at some point it's simply too much. You cannot fill up a balloon which is already full. The stroke volume to measure needs the LVOT diameter, which is not always easy to measure. The pulse width Doppler needs to be in the LVOT, and you have to have an optimal signal tracing, and even more optimal, the body surface area to calculate the stroke volume. Here I have some measurements where you can see the maximum velocity across the LVOT and a calculated aortic valve area, which shows aortic stenosis not below 1 square centimeter, so not severe aortic stenosis, of course, a stroke volume indexed with 73 milliliters per square meters, and an overall stroke volume of 142 milliliters. Furthermore, it is about having a blood pressure which is normal and enough for organ perfusion. So the mean arterial pressure you can measure with cardiac output times the systemic vascular resistance. The systemic vascular resistance, on the other hand, is the venous blood pool, and we will talk about the venous congestion in a bit. And you can also even use ventilation. Ventilation, of course, changes pressures. And you can use this end expiratory occlusion maneuver. So you switch off the respirator for 15 seconds, of course, first pre-oxygenate the patient optimally. If you perform that, you have more venous return. With ventilation, you have reduction. Then you have an intrinsic volume challenge, so that you can also try and see the stroke volume. You can see the signal if there's improvement of 10 to 15% over time. With this intrinsic volume challenge, there will be fluid responsiveness present. Continuing with the LVOT and the VTI, always place the Doppler initially in the aortic valve. You will see a signal which is not displayed very well, but when you move it slowly backwards, the sample volume slowly backwards until you reach the LVOT, you will truly be in the area where you actually measured the LVOT diameter. And here you have the LVOT signal, whereas here you are still in the area of the aortic valve. The VTI, on the other hand, should be around 20 centimeters for the RV outflow and the left ventricular outflow. So the VTI of the left ventricle, the LVOT signal, and the VTI of the RVOT signal. 20 centimeters is in the range of normal. The maximum velocity should be around 1 meter per second. Of course, a visual interpretation of the signal in the acute setting also helps, so still you should be used to those measurements. So simply repeat and measure that you also feel more comfortable with the visual assessment as well. The SVC, we talked about it briefly. The SVC is a continuation of the IVC from a subcostal approach. You can scan it. This is the IVC, so the marker points towards the head, towards cranial, and the continuation with a little bit of sometimes tilting and rotation. You can see another vessel entering the right atrium, which is then the SVC. Here you can see a color Doppler across the SVC, and you see a nice collapsibility in this young and definitely not decompensated patient of the IVC and also the SVC only during this normal scan performed over here. In this case, we have a patient with a recompensated heart failure, where you see again here the SVC. You have to be in the right timing. Here's the SVC. Still there is less collapsibility compared to what we have seen before. Here we have the congestion of the IVC and the congestion. In the last glance, you see the SVC. There is no collapsibility. It definitely looks larger, and optimally you can visualize it in a bicaval view in a TE study. So this is a TE study, a transesophageal echocardiography. So if a patient is already on the ICU and you perform a TE study, don't forget to look at the bicaval view to visualize the SVC seen over here. Here you have another structure, the Eustachian valve, and here you even see parts of the right atrial appendage. This is the interatrial septum, which is hypermobile. So primum septum, secundum septum.